I'm an ENT. Works in Madrid in Hospital Universitario, as you said, and in 2008, I started a research and development project that tried to. Because of its great financial needs, I have to transform in a business project. That project is called Nasal Advanced Systems of Airflow Laboratory, and since then I've worked with the best institutions of R&D in my country, like Universidad Politécnica de Madrid or el Instituto Nacional de Técnica Aeroespacial. Also including other universities, and Manuel and Enrique have worked in Nasal, giving his support in all the project. The aim of our project is to provide the community, the medical community, software or software that could help in decision making concerning not just concerning all the illness, all the alterations in the nasal cavity. As I'm going to present you now the final or the preliminary results of my research. As Catherine told us this morning, everybody knows about nasal airway obstruction. I don't have more things to do with it. Nasal airways, the prevalence, some put like that, the prevalence of nasal airway obstructions is the most frequent symptom in the clinical practice in primary care in otolaryngology consultations. Is the main symptom of one of the most diagnosis in the inflammation of rhinosyncytial mucosa, that allergic rhinitis, that involves almost 20% of the population, and the septoplasty, the main or one of the main surgical procedures, is the most frequent surgical procedure performed by ENTs to improve the quality of life in nasal airway obstruction. What I present you is the preliminary results of sensitivity and specificity in regarding nasal airway obstructions about nasal flow. We have recruited 104 patients, and all the patients were recruited in the section of rhinology where I work in the Hospital Universitario Gregorio Maranon de Madrid. As Ismael told you a few minutes ago, the boundary conditions, I'm not being repeat again all the boundary conditions, as you can see, and nasal flow has been determined as the test problem, and visual analogical scale in nasal airway obstruction has as the test reference, as the gold standard. According the test reference, the visual analogical scale, as according to your post, according to RE, is considered the value 7, as you know, 7 until 8 till 10, as the cutoff point for classifying subject with nasal airway obstruction present or absent is below 7. The test problem, nasal flow, the diagnosis of nasal airway obstruction was assumed if flow rate is below 3.5 liters per minute, so it becomes test positive, and the diagnosis of nasal airway obstruction in the test was assumed if the wall shear stress in the valve was superior than 0.35 in the valve and 0.25 out of the veil. Okay. This is an example of our measurement, and as you can see, these are the results. First, concerning the flow rate. You can see, as you can see, the specificity was almost very fine, and the sensitivity was a little bit below. So if we add the measurement of the wall shear stress, the results change a little, and gives us a very good sensitivity with very positive predictive value. But we have until now we have no very good results in the specificity and negative predictive value. Almost, we are in the verge of more than 53%. The what could be the problem? Where could be the problem in that? Well, the systematic revision of RE in the RE publication showed that patient with nasal airway obstruction had an average in the rhinologic scale with 2.3 standard deviation. That seems a very great variability, and we have to answer the question that is the VAS a very good gold standard just alone? Well, I think that just alone is a little bit poor to present it as a gold standard. And the test problem, the analysis of the total flow of and the rate flow in each nostril, because each nostril has been determined blindly and independently. It's not the correlation is not always good because of the perceiving of the patients. These factors, because many factors may affect the results. These factors include, of course, all the day we have talking about. These factors include nasal cycle state at the moment of the image acquisition, and the outlet airflow diameter. With this, because it's heterogeneity to the cutoff point of the last slice of the CT scan. And for example. Also, I want to point. I want to show you an example of false positive. This false positive shows us that the patient told us that he has no obstruction, no nasal airway obstruction, but our nasal flow said us that yes, he has an obstruction. If you can figure, if you can watch here. In fact, in the choana, the patient has a real obstruction, as you can see in the CT scan, but it is almost beyond the nasal cavity in the choana, and we assume that there are no thermomechanoreceptors that can give sensation of the patient of his obstruction. So, who's failing? Who's failing the patient in his validation, in his visual analytic scale? Is failing the test, the nasal flow? Well, specific and negative predictive values desirable for any diagnostic method are greater than those obtained in this study. So we have limitations. We have work to do because of the limitations of the retrospective study. But we have an observable observational and retrospective study. So in future work, we are working with a prospective study. No more precise gold standard to evaluate nasal airway obstruction. In the next future, we are going to evaluate not just the visual case, adding the nose test. Somehow the difficulty of the analysis of the results. Although nasal flow you can have in a very short time many results or many studies. Perhaps, as you can see in the sample of in one example of false positive, requires quality individual assessment. So it's a little bit difficulty sometimes to analyze all the results that CFD can give us. And as new parameters in clinical study, we have to see another parameters as velocity, outlet area of the flow, and so on. So thank you very much for your attention, and if you have any question, I'm fine.